Assalamu alaikum jami'an. I would like to welcome you all to our grand rounds. Our topic today is about pediatric keratoplasty. Will be presented by Dr. Rafah Fairaq. Dr. Rafah is one of the talented surgeons in our division at KKESH. She has special interest and a vast knowledge in pediatric keratoplasty. So I'll give it to you, Dr. Fairaq.
Thank you, Dr. Mutlaq. Let's start. Okay. Good afternoon. Assalamu alaikum, everybody. Thank you, Dr. Mutlaq, for this introduction. Today, I will talk to you about a topic that I have personally experienced with and gathered some information about during the previous year. It is about the pediatric keratoplasties. Let me take the time to show you this video first. The reason I chose this topic is because of the profound effect it has on the life of a new human being. As we all know, children are a special group of patients. There's many challenges that are associated with dealing with the pediatric age group. This video might be a little bit optimistic, and in order to achieve these outcomes, I'm going to highlight some of the important points to consider during the journey of a keratoplasty in a child. And I call it a journey because it's the beginning of the road and not the end. I'll start with the decision for surgery, some of the intraoperative challenges and post-operative care, and then I will talk about other techniques. Okay. The importance of visual function for a child's development cannot be underestimated. In order for you to actually appreciate the importance of pediatric keratoplasty, you need to understand the visual development and maturation. It's not just about the visual acuity and how much vision the patient has. There's extensive work by developmental pediatricians about the effect of severe visual impairment on the global development of an infant or a toddler. One of the studies looked at children younger than 16 months of age who were presented with a documented normal development on the first assessment, but they had profound visual dysfunction, and it showed how those patients in the blind group has significantly regressed in their development, whether it is in the sensory motor understanding, verbal comprehension, and the expressive language. Then I will talk about the causes of the corneal pathology in children. Stilting, which is one of the first authors who described or published about penetrating keratoplasty in children had given us a very useful classification of the causes. They divided it into congenital and acquired. Under the congenital, there was the Peters anomaly, the corneal edema and associated with the glaucoma, CHIDS, posterior polymorphous dystrophy, and other anterior segment dysgenesis and sclerocornea. The acquired group was divided into traumatic and non-traumatic. Under the non-traumatic, there was all sorts of infection, whether herpetic, whether bacterial or fungal, the keratoconus, the other interstitial keratitis, Stevens-Johnson, and neurotrophic ulcers. Traumatic were any corneal scarring secondary to trauma, whether penetrating or non-penetrating, or corneal blood staining. When we are first encountering a case of a child with a corneal opacity, there are some important questions that we need to address. All right. The first question is the etiology, pregnancy, and birth and family history. Why is that important? Because different etiologies have a different effect on the prognosis of the keratoplasty itself, and also different approaches regarding technique of surgery. Any maternal history of medication or infection or any birth history like birth trauma or anything should be documented. Family history of stromal dystrophies as well should be recorded. The other question is it unilateral or bilateral? And the importance of this also is affected by the outcome. As we know, in bilateral cases, there is the intervention or the keratoplasty may have better visual outcome due to the prolonged plasticity of the visual development with the bilateral equal visual deprivation, unlike with the unilateral cases where there is high competition between the eyes and deep amblyopia can develop early on. The extent of anterior segment involvement, that's another very important factor and has also an effect on the prognosis. For example, if we compare the outcomes of Peters type 1, where there is minimal to no lens involvement compared to the outcomes of Peters type 2, we will find a very significant difference in the graft survival rate. And I'll be talking more into details as we go in this presentation. The state of the posterior segment also is very important. Sometimes it's not easy to assess the posterior pole due to the significance of the opacity. That's where we rely on posterior pole ultrasound, UBM as well, and all of these investigation. Electrophysiology can also help us in determining the retinal function. The systemic status of the child, that's a very important question or something to look at, because many of these, many of the reasons or many of the causes for corneal opacity in children are associated with involvement of vital organs and systems like the heart, the kidney, the liver, and so on. And early intervention can be life-saving in some of these situations. Again, another thing is that with early intervention, it may also affect the kind of surgery or the need for surgery. Like, for example, in cases where for the mucopolysaccharidosis cases, once the enzymatic therapy or the bone marrow transplant therapy is undertaken, the corneal opacity, if it wasn't profound and if it was if treatment was started early on, there's a chance that this opacity may regress and you don't need to perform as an extensive surgery as you would have planned otherwise. The visual function, that's very important. Of course, there's many challenges with determining the visual acuity in this age group. However, we should take as much of a visual acuity that is age appropriate as we can. We can use the visual evoked potential, and we can depend on other clues or subtle clues, like, for example, the presence of nystagmus to tell us about how much is the visual function or how much visual function does this child have. And the most important, last but not least question is the family support and the socioeconomic status. Without the family support, without their understanding, there is no way the pediatric keratoplasty can be successful. Regarding the challenges, I like to divide them into preoperative challenges, intraoperative, and postoperative. In the preoperative challenge, the most important thing is to be sure that when we're deciding to undergo or take the patient for a keratoplasty, that the benefits outweigh the risk, and that we have considered all other non-surgical options or other minimally invasive options, like, for example, optical iridectomies or other alternatives. Another important thing is the multidisciplinary approach. We need a cornea specialist, a pediatrician, a pediatric ophthalmologist. These all have to work hand in hand and give the highest priority to pediatric patients in undergoing keratoplasty. The third member of that pyramid are the caregivers, counseling them carefully about what are the expectations regarding the survival, regarding the prognosis of each diagnosis that their child may have. This all can help in their cooperation. They should understand what to expect and how much commitment and how much time and effort they will be required to put into this whole journey. These are very, very important things and cannot be underestimated. Regarding the intraoperative challenges, of course, for pediatric keratoplasty, there are some differences. It's not like the routine adult keratoplasty. First problem we may encounter is the difference in the scleral rigidity. This causes the eye to become easily collapsible, and also the increased positive pressure in this age group. The younger the child is, the more likely there will be positive pressure. If the pressure was too high and not handled appropriately, it may lead to devastating effect of lens prolapse, vitreous prolapse, and suprachoroidal hemorrhage, unfortunately. Another thing is that the lens and the iris in the young population or the young patients has no positional memory, so they can easily prolapse through any opening that we may create. Increased permeability of the iris vasculature leads to higher exudation of fibrin and protein and higher inflammatory response post-operatively. Regarding the post-operative complications, I'll be discussing it later on. The visual rehabilitation and the amblyopia management. The earlier that we can start the visual rehabilitation and the amblyopia management, the better outcome that we can have. So in preparation for surgery, I included this part because sometimes we as ophthalmologists, we overlook the importance of anesthesia and their role in making our surgery easy and more feasible. The anesthesia should be developed by someone, delivered by someone who is familiar with pediatric anesthesia. The use of non-depolarizing, paralyzing agents, like, for example, the succinylcholine, decrease the chance of development of muscle contraction and the subsequent increase in the pressure. Other tips that may help in decreasing the posterior or positive pressure is placing the patient in a reverse Trendelenburg position where the head is higher than the rest of the body, using a Honen's balloon, hyperventilating the patient to decrease the end-tidal carbon dioxide concentration, and decrease the central venous pressure, which in return will decrease the vitreous or the posterior pressure. Using IV mannitol 15 minutes before before we start the surgery is also recommended, with, of course, adherence to the acceptable pediatric doses. I'll go through this video with you as we watch a case of pediatric keratoplasty. Of course, the use of Flaring cannot be underestimated. It's very important. It will help you. Very controlled entry to the anterior segment is very important. A lot of people advocate the injection of OVD before opening before starting the trephination to avoid traumatizing the lens. Removal of any adhesion between the iris and the lens is also crucial. One of this technique developed by Price called the sandwich technique is a way to minimize the time where the eye is an open sky. That is, you saw how he cut the graft and he put sutures, then he applied visco and put the donor graft, and then he pulled out the original cornea gently. Regarding graft choice or choosing the graft, it's very important to have high quality graft with high density endothelial cells, healthy epithelium, and so on. Ideally, the depth storage time and the time in storage media should probably be short. However, this cannot be always controlled, and there is no particular studies that determine the exact limitations for the time, depth of storage time, and the duration of preservation. Having a donor cornea less than 4 years of age may make surgery difficult, because it will be difficult to manage the corneal tissue. And the younger the child is, the more the younger the child, I mean the donor is, the more steep the cornea is going to be. This can be helpful in cases where there's combined lensectomy and the patient will be left aphakic, where the steepness of the resulting steepness of the implanted cornea can compensate for the hyperopia from the loss of the lens. However, if the patient is phakic, it may lead to very high myopia and difficulty in managing the anisometropia post-operatively. Oversizing the graft is also very important, because these patients, as I mentioned, their iris and their lens have very low positional memory. So they tend to become shallow, and they tend to develop peripheral synechia. So having a larger donor to graft difference help in maintaining the AC and decreasing those the chances of having those paths. After surgery, of course, we all know that children have very intense inflammatory response, so they have to be kept on higher dose of steroid and for a longer duration of antibiotics. And as long as the sutures are there, it is advisable to keep them on the antibiotics, because children cannot really express the symptoms of having the early symptoms of developing any problem with their sutures or microbial keratitis or so on. Topical cycloplegics are important because of the inflammatory reaction, and as I mentioned, the intense fibrin exudation in the anterior chamber. Frequent follow-ups. This is very important, that these patients understand that they will have very frequent follow-ups, especially in the first 3 months post-operatively and in the first 2 years afterwards. Early suture removal, because these patients have earlier scarring, and this will lead to loosening of suture and the expected problems that come with that. Sutures should be removed between 4 to 6 weeks in infants, and as a rule, we add 1 month to the 6 weeks for each additional year of life. Post-operative visual rehabilitation. Cyclorefraction should be performed as early as possible, even with the presence of suture, and the patient should have wear the correction that he or she needs. Frequent refractions will be made, and the parents should understand that there will be frequent removal of the glasses. If the patient is aphakic, monovision contact lenses can be given, or bifocals, depending on the preference of the family and the cooperation of the child. Treatment of amblyopia also, as I mentioned, the early you start the treatment and the visual rehabilitation, the better the outcomes that you may get. Sometimes we need to do combined procedures. Like I mentioned, sometimes the corneal opacities are associated with other anomalies, whether they are the adhesions between the cornea and lens that occur because of the collapse of the anterior chamber, whether it is a lens opacity, lens deformities, and uncontrolled IOP. All of these procedures can be performed. However, they have a detrimental effect on the prognosis of the graft. If a concurrent procedure was performed during the time of the transplantation, particularly lensectomy or vitrectomy, the chances of graft survival are less and the visual outcome is poorer. This is why it is better to try to avoid that or to have it planned ahead of time. For example, sometimes lensectomy cannot be avoided because with the positive pressure, the lens just prolapses, or because of the shallowing of the AC, you may traumatize the lens during your surgical technique. However, if that is avoidable, that would be much better, or at least it should be planned, because lensectomy is performed and a vitrectomy, a thorough vitrectomy and a posterior capsulotomy should be performed as well. Regarding the outcomes, now here is the important thing, which I think that everyone is interested mostly about, is the outcomes of keratoplasty in children. There are many factors that contribute to the outcome. First of all is the diagnosis and the cause or the etiology of the condition, because some etiologies may have more favorable prognosis than others, as I will show you in a few seconds. The age of the child, it's variable. Some people, they say the younger the child, the less risk of survival. However, there's an interesting concept that the infant's immune response or immune system is yet to have matured if the patient is younger than 6 months of age. And this causes or results in less chances of graft rejection. But once the patient is 6 months or older, the immune system have developed, and the higher chances of rejection is applicable here. Overall, the graft survival, as we know in penetrating keratoplasty in children, is lower than that in adults. One of the important prognostic factor other than the etiology is is the post-operative course. Like, for example, the patient developed rejection, the patient developed suture-related problems and infection, or has the patient had the proper management of his refractive error or amblyopia. One of the earliest studies published about penetrating keratoplasty in 1984 by Stilting is this study where they reported that the clear grafts at 1 year were only in 60 patients with congenital opacities, and for the acquired cases, they had a higher rate of keeping their grafts clear at 1 year, with a rate of 70 to 73% of the patients. However, regarding the visual acuity, only 29% of the patients with congenital causes and only 45 to 67 of the acquired causes had vision better than 2400. This indicates a very important message here, that clarity of graft and the survival of the graft does not really mean, or does not necessarily mean, a good visual acuity, because as we mentioned of the effect of the amblyopia and all of that. Some of the risk factors that were found in the study for failure is the younger age, and like I told you, at the time of the surgery, congenital cases had less survival rate than the acquired cases, and preoperative vascularization, persistent heel defect, and performing lensectomy, vitrectomy had higher association with poor graft survival. Whenever we talk about the outcomes of keratoplasty, we cannot overlook a very important landmark study that was conducted here in KKISH. The primary pediatric keratoplasty indication, graft survival, and visual outcome. This study looked at 165 primary penetrating keratoplasty that were carried over 13 years between 1990 and 2003. It included any patient less than 12 years of age undergoing primary keratoplasty here at King Khalid Eye Specialist Hospital. And I will go with you in details of the outcome because there's a lot of interesting messages. First of all, the interesting thing here, of course, they followed the classical criteria to divide the etiologies. But the interesting part here is that the most common cause for corneal opacity needing keratoplasty here was the congenital glaucoma, followed by CHED. They together compromised about 2/3 of the total corneal congenital opacity etiology group. This contrasts with the other landmark studies published in North America and so on, because in their studies, they had the most common cause was the Peters anomaly. One of the explanations that may explain this contrast or this variation is the higher rate of consanguinity here in Saudi Arabia, as we know, and we both know that the congenital glaucoma and the CHED has some sort of a genetic etiology to that. So this is why we maybe we have higher percentage of these people, these abnormalities compared to the North America group. In the traumatic group, it was the penetrating globe trauma. It was the most important cause, and the non-traumatic were mainly the infectious keratitis. Another important or a strength point in this study, that whenever other studies have looked at the survival rate, they would group the congenital group or the congenital etiologies together in one group, and they would report the survival rate of that group, and then they would report the acquired group on its own. The problem is that there's very big difference between the congenital etiologies in terms of their graft survival and the chances for developing good improvement in vision. Like for example, if a group comprised more cases of Peters anomaly, they would have had higher rate of graft failure in comparison to a group where CHED was the predominant congenital etiology. So the good thing here in this group that they segregated the etiologies into 4 categories instead, and they separated cases caused by congenital hereditary endothelial dystrophy in a separate group. This gave us a very precise and more accurate indication of the survival rates. They found that 44% of the primary graft remained clear at the last follow-up, and only 55, and the other 55.8% have failed. The follow-up duration the mean follow-up duration was about 50 months for the grafts that were clear, which means they sustained good duration, and 6 months for graft failure. 65% of the failed graft occurred in the first year, like you can see here. And in the second year, about 88% have failed. This gives us an important learning message here that most of graft failures occur in the first 2 years after the penetrating keratoplasty. And this also encourages us to have frequent follow-up, especially in the first few months of surgery. Like, for example, for the first 3 months, we can see the patient every 2 weeks, every 4 weeks in the remaining of the first year of their surgery, and then we can see them between 6 to 8 weeks. Frequent follow-up is very important for the maintenance of successful outcome. There was no correlation between the corneal donor age, death to preservation time, media storage time, or donor endothelial cell count and graft survival, which is also an important point. Regarding the indications, like I showed you, or like I told you earlier, that different indications have different effects on the prognosis. We see here that the graft survival among the non-CHED congenital opacity were between 40%, while the CHED group had an 85.7% overall graft survival. It was the highest among all of the other categories. The acquired non-traumatic had the lowest, which is the 27.8%. Also, the probability of graft survival over 1, 2, 3, and 4, 5 years was also highest among the patients with the CHED group. This highlights the favorable prognosis of the congenital hereditary endothelial dystrophy among other congenital causes of pediatric keratoplasty. Regarding the patient's age, regarding the patient's age, there was a higher graft survival rate as the patient was older. However, it was not statistically significant. A comparison was conducted also regarding the combined procedure. If any eye had an additional surgical procedure, there was a statistically significant greater rate of graft failure than those who did not have another combined procedure. Most importantly, we see here the glaucoma had a 28% rate of graft survival when done simultaneously, cataract, and the vitreoretinal surgery as well. Eyes that had control of their IOP or their glaucoma, whether surgically before the commencement of the keratoplasty, had better rate of graft survival, although it was not statistically significant. However, having cataract surgery delayed to either before or after the keratoplasty was associated with a statistically significant better graft survival. Then the important the most important complications here were glaucoma, development of high IOP after surgery, and microbial keratitis. The most important thing here is the visual outcomes. Among all the participants of the study, only 36% had ambulatory vision. Compared to, but however, that is an improvement to pre-operatively, where only 18% of them had ambulatory vision. Patients who have vision more than 2200 were only 19%, and only 4%, 8 cases out of the 160 something, had vision better than 20/40, which is a very rare finding in those a group of patients. Eyes with SHED had significantly higher or more likely to achieve ambulatory vision or vision better than 24/200. However, none of the groups were more likely to obtain vision of 2400 because it was a rare finding anyways, and the number of the patient was not adequate. Penetrating keratoplasty has always been the most commonly performed type of keratoplasty in children. However, during the past years, starting 2005 to 2008, trends have started developing into performing lamellar keratoplasty and endothelial keratoplasty. And I will talk to you more about these. When you are considering a patient with a partial thickness etiology or pathology, it is very important to consider DALC, especially if the endothelium or the descemet membrane is spared. Why? Because there are many reasons for the superiority of the lamellar keratoplasty over the penetrating. First, has a lower rate of rejection, avoids intraoperative problems, there's no open sky duration of the surgery. It offers some degree of protection against blunt trauma, and it has a lower astigmatism and faster visual rehabilitation. And that's why it's only fair to consider that. However, there are some challenges with performing the lamellar keratoplasty. The most important indications or the most common indications are, for example, the dermoid, the congenital hereditary stromal dystrophy, metabolic storage disease like mucopolysaccharidosis, keratoconus, infectious keratitis, and other causes of partial thickness corneal scars. An important study was done by a leader in pediatric keratoplasty, Dr. Asim Ali. He conducted a study where they performed the DALC on 50 eyes. Clear DALC was maintained in about 96%. And that is a very good number in comparison to the number of patients who maintained clear graft, which was around 44% in the full thickness keratoplasty. He had some of the patients needing regrafting, and they did also maintain the new graft clarity. His most common indications were mucopolysaccharidosis and keratoconus. Other indications are mentioned. The most important complication was microperforations during surgery. However, they were not significant enough to warrant conversion to penetrating keratoplasty. In patients with unilateral partial thickness, an important finding or an interesting finding was documented. They measured the endothelial cell count in patients who had unilateral surgery. This way they could take a measurement of the other eye and compare with it. And they found that there is significantly lower endothelial cell counts in the operated eye in comparison to the non-operating eye, which was about 8% decrease. And interestingly enough, none of these eyes had microperforation during surgery. One of the most important factors for failure was the corneal neovascularization preoperatively and the number of quadrants of this new vascularization. For endothelial keratoplasty is also, it has become a trend since the first one was performed. I think it was 2005 or 2008. And ever since then, the trend has been rising to perform endothelial keratoplasty in children because, again, it has a lower rate of rejection. It avoids the intraoperative risk of associated with the open sky technique, no suture-related problem, and very minimally induced surgical astigmatism and earlier visual rehabilitation and amblyopia treatment. However, it is not without challenges. A study conducted and published in Cornea about the outcomes of the DASEC in a pediatric age group. It looked at 180 DASEC from 2008 to 2020. It showed that 86% maintained a clear graft. That's still, again, a very high percentage. However, median best corrected visual acuity only improved from 2500 to pre-operatively to 20/160. Long-term graft survival was high. It was 92% in the first year, 86% in the third year, and 77% in 7th year. This is also very promising results. Another systemic review that I found showed that SHED was the most common indication. 49% of the eyes had best-corrected visual acuity improve, and the graft dislocation was the most commonly reported complication. There was the rate of decrease in endothelial cell loss about, it was variable between 8% to 63%. We come to a very important aid, I would say, in the decision for our second step in the case that graft failed. As we have seen, there is a considerable high rate of graft failure. What about the repeating of the graft? We all know that the success of a second graft is usually lower than that of the first. In a very important landmark study also in North America by Dr. Dana, the graft success rate decreased from 78% in their primary graft to only 19% in the second graft and 0 success rate in the third graft. Wow, that's a very huge drop. Younger children, usually in adults, okay, we wait until like at least 6 months before we repeat a failed graft because we want to decrease the inflammation, optimize the eye and the ocular surface to receive a newer graft. But in the case of a child, unfortunately, we may not have the privilege of waiting for 6 months because of fear of developing amblyopia. So the average duration of repeating the graft was 3 months of age, of duration. Okay. In conclusion, pediatric keratoplasty is a holistic approach. It's not just a clinical diagnosis or condition. Yeah, sometimes the improvement in global development in a child, as we mentioned in the earlier papers that were published by the developmental doctors, the improvement in global development may justify the decision for having a keratoplasty, even if we know that it will fail. And to define such success is very difficult in the cases of keratoplasty. Sometimes success can mean having a spare eye with ambulatory vision rather than losing the eye completely. Newer techniques are in horizon, whether it is using assisted femtosecond machine for achieving lamellar keratoplasties and all of that. And we remain optimistic and hopeful to the future. Thank you.
Thank you, Dr. Fairaq, for a wonderful lecture. I'll open the floor for questions, and I'll start with the first two questions. The first one regarding the consent and the preoperative approach toward patients and family. Should the lancectomy be part or a routine while consenting patients for penetrating keratoplasty? What do you think about that?
I definitely think so. If you know me, you know how thorough I am with my consent. Sometimes it even scares patients off, but I feel that it is their right to know. It is very important for them to have realistic expectations, and there is just no way for you to expect or even prevent that from happening. The younger the patient is, the higher the likelihood of the patient developing extrusion of his lens and the vitreous. So definitely the parents should know about this possibility, and also they should know about what are the consequences in terms of vision and in terms of visual rehabilitation of this problem if it occurs.
And the second question is related to the congenital etiologies of corneal opacities. Now, what's the ideal age to perform a penetrating keratoplasty, given that the eye sometimes gets bigger and the opacity relatively gets smaller? You can approach them with iridectomy or different things like dilating drops. So was there a mean age for in the studies that you went through?
Well, surprisingly, I've been through a study. It was like a survey about the trends of keratoplasty, where multiple cornea surgeons were asked, or a questionnaire was sent out to them to ask about the age of performing surgery. Many of them have said that the best outcomes are when the patient is less than 6 months of age and the first 3 months of age. Because that's when the visual maturation and the development occurs. Because as I mentioned, having a clear graft is not enough. The problem of amblyopia can affect the outcomes of your surgery. And some people, they rationalize that it's okay, we let the visual maturation develop for the patient, and then we can deal with it rather than keep him with a dense amblyopia secondary to the occlusive nature of his pathology. And then even when you do a graft, there's no point of improving his vision. Some, they do it early, let it fail. At least the patient has matured. At least the patient has had developmental growth and development.
And given that putting drops in pediatric patients is difficult, would you recommend, or do you have any idea what if systemic steroids or immunosuppressives at this age are better, or were there studies talking about that?
I'm not sure I came across something in particular addressing this, but I would say that this has to be tailored according to each situation or each patient's health and how much they tolerate and the age of the patient and his weight and so on and so on. But one of the tips or the surgical tips was using at the end of the surgery in the injection of deposit of triamcinolones or this kind of thing would have an extended release, or it stays a little bit for at least the first couple of days where the inflammation is the highest.
Thank you. Thank you so much.
Thank you.